So I think we can start. Feel free to sit closer so we can have more intimate discussion. So I hope you are enjoying today. I know it's a very packed day for today, but we want this session to be much more interactive so that you can tell us how we can work better together with you. I'd like to invite my colleague, Dr. David Novillo, to the stage. I introduced myself earlier. My name is Yongjie Yon. I am the technical officer for the Aging and Health program. Aging is a very cross-cutting topic, and so it's my opportunity to also work across the house and, of course, together with David to explore various issues. And so today we will speak about, introduce a program on data, artificial intelligence, and digital health. In short, it's called DAD. The DAD program is here. And then, of course, Dr. Lydia Lazari, who is joining us virtually later to speak about the mental health programs. And so, without further ado, I would like to invite David to come up to share a little bit about his work and to have a bit of a discussion. And so I hope we can think about the partnership that we have to work together and perhaps examples from your cities and communities what you are using on data, artificial intelligence, or digital health, how we can work better. So David.
Thank you, John. Hello, colleagues. Good afternoon, and thank you so much for staying in the room. I know that this is coffee time, so I really appreciate that you are staying here. So as Yongjie introduced me, I am David. I am the responsible officer for the Data, Artificial Intelligence and Digital Health program. And I would like to start apologizing because if there is an area in which we need to look more for the older adults is on data and digitalization, because we are dramatically failing. So I look forward to learn more from you, particularly about your views. What we agree with Yongjie is just to give you a quick overview about the current activities that we are conducting overall on data, artificial intelligence and digital health for around 15 minutes, I hope, or less. And then to give at least 15 minutes for you and to learn from you about your views, experiences, etc. And of course, we can continue being in touch after this event. When it's about WHO mandates about digital health, there are two mainly. One is a global digital health strategy that was adopted in 2021, so years and years ago, that is going now to be reviewed and presented as a new strategy for the period 2028 to 2033. So I think that this is a good opportunity for all the inequalities that we can already see to try to work on that. I didn't mention when it's about at the regional level, in 2022, we have a regional digital health action plan that basically was making an operationalization of what was discussed at the global level for our European region. A list of things that we are doing overall, and apologies that I'm not going to focus on older adults or health in aging overall, but just to give you an idea, and then perhaps you can also reflect on, hey, about this product, why you are not doing this or that. That will be very helpful for us. So these are just a few activities that we usually we are asked by our member states to provide and to deliver, but also that are happening at the moment. So I will say that these are the 11 areas of activities that we are doing at the moment. Apologies also for my quick speed. As a good Spaniard, apologies. I would like to try and calm down myself, and otherwise, apologies in advance for my speed. And one of the most activities that we are requested is conduct health information system assessments. So as Yongjie mentioned, as part of our team, we have the data component that is the pure data component. It's how we collect data from the member states and how we use this data for policy decision making. What we do with this kind of work is basically to first to conduct a semi-structured a desk review of what is happening in the country around data. Then we have a visit in the country for a week when we conduct semi-structured interviews, and then we provide a report in which, with all the findings, we support the country in how to improve data. When it's about healthy aging, even if late, we are starting discussions. The major data set that WHO Europe has is Health for All. I don't know if you are familiar with this database, but it's the most important database for knowing the status of the health situation in the WHO European region. So we are currently establishing a working group on what could be changed and added looking at healthy aging. So that is something that will start actually next week. We have a working group that we are going to establish with Yongjie support and others that is looking at healthy aging and long-term care, looking at what else we can do better about this. And of course, our data will be as good as the data from the countries, right? So first we need to ensure that the country is collecting this data, because we cannot start in collecting data that doesn't even exist, right? And Lydia will talk more about that for sure when it's about mental health. This is just what I mentioned about the structure and how we conduct these assessments, so I want to stop on that. As part of our work, we also support countries in developing health information strategies. Of course, for Nordic and Baltic countries, almost all of you have already a data strategy or health information strategy, but our region is quite diverse, so not all the countries in our region have this kind of policy documents that are needed to really measure progress, even at the country level. Another piece of work that we are developing is the part related to supporting countries in developing digital health strategies. Currently, in our region, 83% of our member states, looking at the 53, already have a digital health strategy, which is good news from a policy point of view. If you are asking me about implementing these strategies, that is a different discussion for which I do not have the data, but definitely the numbers will be quite different. So as part of our work, we support our member states in also having these kind of policy documents that are helping them to move in digital health overall. Something that we have been also asked lately is about conducting cybersecurity and privacy maturity assessments. This is something that is happening more and more, and you can see in the news how hospitals are breached with the data, big companies, ministries, etc. So we are trying to support the best that we can in conducting this kind of cybersecurity assessments to support countries, particularly at the hospital level, is the main support that we are providing to the member states. These are just some slides about this. Another piece of work that we are also asked frequently is digitalization of health information systems. So, of course, we know that we want quick wins, so digitalization is something that is in every single speech of a politician, and we fully understand, right? So I don't want to be politically incorrect, but sometimes we forget that if we have broken data systems, if we digitalize, we are going to have broken digitalized data systems. There is not going to be difference on the quality of the data, right? So sometimes there is this disconnection between the need for improving the data quality and the data itself with the digitalization of this data. This is something that we try more and more to convince our member states to really work on the data before we discuss digitalization, right? And then as part of this, and also talking about inequalities, we have conducted a few pieces of research when it's about inequalities. One was published 2 years ago, and of course we saw that the older adults are definitely left behind when it's about developing digital solutions, right? And now we are due to publish another review on how overall the population is involved in developing, designing digital solutions, and the findings are exactly the same. So it's a complete disaster. So we have this mantra that we need to definitely involve the population at all levels when it's about developing digital solutions. And it's quite frustrating that we are failing this again and again and again. So what we are developing as part of these research efforts is to develop a tool that hopefully will support member states in how to involve the population in developing the digital tools even in the early stages. This is something that is also linked to trust, as you know, for sure. And this is we are fully committed to at least to put this on the table. Sometimes our job is just to put things on the table and start discussions, right? And we can take it from there, because at the end we cannot force the member states to take this forward. But at least we know the problems and we try to tackle these problems that are not easy at all. And of course I will love your views also about how to motivate member states so this is not left behind each time that we move with digitalization. More about trainings that we conduct. So when we look at digitalization of health information systems, just for you to know, we go beyond the pure digitalization, computer, IT infrastructure issue. We look at everything related to legal policy framework, integration of interoperability, the security and privacy part, but particularly also the issues related to the workforce, financing, how this is done. These are things that are changing constantly, and I think that most of the time we also forgot about what is needed to digitalize beyond what we usually do and what are usually doing when it's about buying laptops, computers, equipment, and doing this IT infrastructure work. Another important piece of work is on telemedicine, and we developed recently a support tool to support countries in how to establish telemedicine services. And actually, a few weeks ago, along with Yongjie, we published a review on the impact of telemedicine in dementia care. And we were very proud that we took that piece of work forward. It took us almost a year to do it, but we think that these pieces of work have a lot of attention also to put the issues on the media so they can pick up from there, and then we can continue making some progress. Some modules about what we're looking when it's about telemedicine. Basically, first assess what is happening, to develop a strategy, and then to plan for organizational change. In our region, the data indicates that 78 of our member states are already using telemedicine. That increased a lot during the COVID-19 pandemic, as you can imagine. So most of the services established during the COVID-19 pandemic actually became established formally after the pandemic and now are widely used. And I think that for almost all of you, teleconsultations is something that is completely normal nowadays. More work that we are doing also is about geographic information systems, supporting countries, for example, in mapping health facilities, having hospitals, primary healthcare centers, even doctors, to have a control that is helping a lot, particularly for planning and for policy purposes. So that is something that our team is also covering when it's about WHO and the digital health portfolio. Also, as part of our portfolio, we have the WHO family of international classifications, of course, including ICD-11, that is the latest version of ICD that we have, and that is currently being widely implemented. More work that we have been conducting also for member states is, as you may know, as part of the EU, the European Union has the official EU country profiles on health. So in our case, WHO Europe is responsible for covering the non-EU member states and to develop similar profiles with the support of the European Health Observatory. So this is also very useful for a country to know how they are doing, but also to be compared and benchmark with other countries across the European region. Another interesting product that we offer and we develop as part of our portfolio is establishing knowledge communities. And this one is quite interesting and maybe it's also of your interest, and that is something that we can definitely offer you. So as you know, there is a lot of explicit knowledge, right, that is already published in the evidence, in the literature, which is fine. But there are particular areas of work, as in digital health or artificial intelligence, that there is a lot of tacit knowledge that is with us, but is still not in the literature. So with these knowledge communities, what we try to do is to put together experts with this knowledge that is still not translated in the available evidence and trying to put that forward as WHO. We have currently two knowledge communities working at the moment, one on the ethical use of AI, sorry, and another that has been recently launched on how to measure digital mental health solutions. So that is something that also, with the support of the UK, we are looking at how we can support the regulation of these tools that are happening at the moment, right? That, of course, have a direct impact also on healthy aging. A knowledge community is not a network. A knowledge community usually has a clear beginning as an end. So we say approximately that the duration of this is like 6 weeks. And during these 6 weeks, every week we have a topic to discuss. So as a result of this discussion, at the end, we will produce an executive report, so what has been discussed under Chatham House rules during this knowledge community. So this is something that sometimes, when the evidence is still not solid enough, help us to move forward in specific topics. When it's about, in particular, on artificial intelligence, something that we are currently looking at the moment, very briefly, is first developing some use cases. One is about health workforce, mental health and quality of care. That is something that we are currently developing at the moment. We are also looking at how, with data, we can host and sponsor hackathons on innovation challenges, also for this topic. We established last September a technical advisory group that is advising WHO Europe and our regional director on AI issues. We have established also, we're establishing a roster of experts on artificial intelligence, because honestly we do not have enough capacity in-house to really work and deliver on this specific area of work. Last week in Malta, we launched the first regional report with 43 member states attending this event, but 50 out of 53 member states replied to the survey. So this is the first and unique regional report, and I'm so happy to see Hannah, that is one of the co-authors of this report, with what is happening in the European region. Of course, there is a lot to improve, but honestly, we need to be very thankful, and we are very thankful that 50 member states agreed to share the data, even knowing that the data, it won't look good at them. So I think that we need to value that a lot, because sometimes we miss the importance of sharing data with organizations like us, and this is not a blaming exercise. The only way that we can improve things is measuring things. So I know that when we look at WHO, and the 5 remaining regions, in other regions of the world, we are the only one with clear data to know what is needed to move forward in this area of work. And for that, we are still grateful to them. Because, of course, as you can imagine, any headline that you may read from last week, if you have been following or by accident you have seen this, everything is very pessimistic and negative. Again, there is a lot of things to improve, but there is a lot to celebrate, right? At least we know what the problems are. And that is something that is very manageable. So just I wanted to reflect on that, because again, it's very important that when sharing data, and particularly now that I mentioned that we're going to start discussing this exercise about healthy aging and looking at the proper indicators to measure healthy aging and to make progress, that we are also encouraging our member states to do it in a very constructive way, so they don't see this as a blaming mechanism. That is how usually these exercises are done, particularly for the media, right? So as a next step of this baseline exercise that we presented last week in Malta, the next step for us is to develop a regional roadmap on AI for the European region. So that is something that we are very committed, and we are going to be establishing a member states working group for working on this roadmap, that it will happen, hopefully it will be presented in the next regional committee in 2026. Then we will, of course, continue providing support to member states on developing these national strategies. And then the report, that is the last point, is the report that I just mentioned that was launched last week. So the next of the slides are just a translation of these 11 items in trainings that we already have. So basically everything that I have been presenting is offered also as a training for the member states for capacity building purposes. So with that, I think that I will stop here because I am very interested in knowing for you and receive any feedback that you may have. Thank you so much.
Thank you, David. So This is a good overview of your programs, and I'm really interested to hear from your perspective about how you think we can work together. Maybe while you think about this, my question to David is, you have a whole range of activities to support member states that we call country. Do you engage with cities and local communities? And I like what you said earlier. We are the region with a lot of data, may not be perfect data, but we have something. But the same is true for local cities and communities, that you have data to improve and work on your programs. So what do you say to that about working with community?
Thank you, Yongjie. So I would say that in short the answer is no. And I'm not going to try to justify ourselves or WHO or myself, but I think that the main issue, particularly in this area of work, is the lack of available staff. So we have been trying to engage with EU countries, just to say EU, because sometimes when you say EU, it looks like it's better than other parts. I know that is not politically correct. And sometimes we don't even have a focal point to work with in this area of work. So what is the reality? So when you try to interact with a country, you say, could you please put us in contact with a focal point on artificial intelligence? There is still no focal point. And the same happens with digital health. With data, sometimes it's easier because you have the National Statistics Office, and sometimes we are just referred to the office. But when it's about digitalization, not to mention AI, it's quite challenging to find the right person to move in this area of work. So if we extrapolate that to the local or city reality, of course, it's even more difficult. So I know that sounds like a poor excuse, but that is the reality.
Any ideas how we can explore opportunities with cities and communities, or even perhaps cities region? Because I know, as you said, 83% of our regions have a digital health plan. Do they actually involve local cities? Is there ways to work together?
So as part of the methodology when we conduct the survey, and of course we don't validate that, and of course this is part of the limitations of these reports, as part of the methodology we ask the Ministry of Health, that is our official counterpart, to ensure that the group that is responding to the survey is representative enough to give an overview of the country. But of course, as you can imagine, that is quite challenging, right? Even I will put my country as an example. I have a country from Spain with 17 regions. So how do you agree in putting 17 views in a national survey, not talking about even the city level, right? So we know that sometimes it's very difficult to have a broad overview about this. But about engagement, I think that these exercises that we are conducting as the knowledge communities are an entry point for cities and local communities to really engage with us and to work even closely. Of course, you can do it directly without doing and joining these knowledge communities, right? And actually for this working group that I mentioned at the beginning on data, if you have any interest in being part of this working group as an observer or as a reviewer in due time, we will be happy. Please just reach out through Yongjie. I don't know if my email will be in one of the slides, but otherwise, please feel free to reach out through Yongjie, and we will be happy to include you as part of this working group that will be developing thinking of indicators that will help us to measure this.
That's actually really important. I mean, part of the principle of age-friendly environment is always working with other persons, working with the end users. And of course, we always see the impact at the local level. So it's great to be able to be part of this working group to maybe explore this knowledge communities hub as well. Any questions, thoughts, comments, or if you'd like to share some of the initiative in your local communities? So there, and then to Kai. Perhaps introduce yourself and then start.
Okay, I'm Jonas from Eskilstuna municipality in Sweden. Can you just give some examples of these knowledge communities that you mentioned? Are they up and running, some of them, and are you planning some? And can you say something more about that, please?
Yes, thank you. Yeah. So the knowledge communities that I mentioned, one is in the ethical use of AI, and another on digital in the assessment of digital mental health solutions. Both of them are currently happening at the moment, so both are up and running. Just to be very, very open about how they are running, right? At the beginning, for the first knowledge community, we had 1,000 people interested. They were very happy. There was no selection processes about this, so every person that was interested in joining was automatically accepted, with the exception that if they didn't, we said that they need to agree with our code of conduct. If that was not marked, they cannot be included because there are some rules to follow, right? For respect also to other colleagues. I am sharing this as an anecdote, and then I will elaborate more about the knowledge communities. So, as I said, 1,000 people. I think that we're in week 4 or 5, and we are down to 60 people, I will say, that are really working on really helping us. With that being said, I'm very happy that we are still keeping 60 people that are very engaged, very professional, trying to really work on what we agreed at the beginning, right? Because we saw a lot of enthusiasm on LinkedIn about saying that they are part of something, and then looking at who was saying that is part, and then looking at the names that are in the knowledge community, there is a mismatch, right? So unfortunately, sometimes when we put things together, it's a bit discouraging also for us, that we try to do things with good intentions, and then at the end, it's not meeting the objective. We're still curious about what will be the outcome of these knowledge communities, but I think that it will be very positive at the end. So as I mentioned before, each knowledge community have like a clear timeline. So week 1, we are discussing about, just as an example, concepts. Week 2 is about example of violation of ethics. So every week has a clear timeline and a script, so people can have these discussions through a moderated platform. We are not, everything can be set there because again it's under Chatham House rules. The only thing that we don't allow is private companies to start putting private solutions. That is also our part of code of conduct. But again, as soon as we finish, we will produce an executive report with all the contributions, expecting that it will bring some value added to the discussion, right? So imagine that for your municipality or city, you would like to do something specific in a topic, we could support you with that. So unfortunately, the 2 knowledge communities that we have right now are related to our area of work, but this is open to everything, right? So you may have something in mind that, hey, why we don't ask about X or Y? That is something that we can do and we can offer, and that is something that it will be a pleasure for us to offer. Just keep in mind, please, that also this requires resources, not for us, but the maintenance of this usually is quite heavy, right? You need a person that is monitoring what is said, ensuring that there is dynamics in the discussion, but this is very useful to really have a knowledge community. Limitations, in we are looking at the older adults and we are looking for them to be involved, we know that there is a gap for them with digital skills, right? So it will be also to analyze how useful will be a knowledge community, depends on the audience that we are targeting. Hope that clarifies. Thank you.
And Kai.
Yes, thank you for an interesting presentation. My name is Kai Koivumäki and I'm working at the Nordic Welfare Center, which is one of the organizers of the seminar. And I just wanted to ask a little about regional cooperation because we are working mainly with the Nordic countries, but in certain occasions also, of course, with the Baltic countries like today. And we are a knowledge organization and we are publishing knowledge concerning good practices and policies and which the countries and the policymakers in the countries to take and work on their policies on the basis of our publications. Just a question concerning for example, regional cooperation. Have you done it with some regions in the world, could there be some possibilities for regional cooperation? Concerning the Nordic-Baltic region, there is a statistics and indicator cooperation going on under the Nordic Council of Ministers. It's the Nordregio, which is our sister organization located in Stockholm, who are responsible for the statistics. We are more practical in our organization. But and have you had some cooperation with the Nordic statistics cooperation, for example, before? Maybe there were a lot of some unclear questions, but but maybe you got something out of it. Thanks.
Yeah, absolutely. Thank you so much, Kai. So, so at the regional level, I will say that with the only region that we have formally established is with the Central Asian republics, with these 5 Central Asian republics, and we meet regularly on health information data issues. Then we have a more established regional level for our region in total, and we have 50 countries. So that is the Health Information Network. So that is the most established and formal network that we have when it's about data and health information systems. But we would love to have something with the Nordic and Baltic countries. That is something that we don't have, and for sure will bring some value added. So happy to have a follow-up discussion to ensure that that could happen. I think that in the past, the main challenges that we have found is that establishing a network is relatively easy. Keeping moving it is usually challenging because also, or we change, or in the countries there are changes, so usually it takes us a lot of time to really have some things moving. That has happened, for example, as a sample that with constructive criticism I can share with the Western Balkans. Usually it has happened. We have tried several times, but from time to time it's very difficult to follow up due to the changes, even on our end, on the end of the network. But definitely will be something that we would love to explore.
I have one last question for you, David. You mentioned that part of our work is to provide assessments and support for countries when countries ask for this. Could city ask for support in this, and what do they have to do for that?
Yeah, absolutely. So if there is any of the tools that you have seen that is of interest, of course, we'll be happy to provide this support and cooperation. So, I mean, we don't work just for the ministry or the minister, right? So we work for the whole WHO European region that includes 53 countries, and of course, all of you. So if there is anything in particular that you are interested, we will be happy to have a follow-up discussion. Absolutely. Yeah, with pleasure.
Great. Thank you very much.
No, thank you so much
No
to
more
all of you for
questions?
making the time. And I hit my...
Just
please.
one more. You can introduce yourself.
My name is Wei Kiat Bong from Oslo Metropolitan University. My question is about the topic that listed there, especially about mental health. I'm a researcher within loneliness for older adults, but then I'm just curious about the topic you guys work on, because for me, mental health covers a big range. So do you guys have any very specific directions about that?
On mental health and artificial intelligence, or in general? Okay. So in mental health, we have been exploring a few topics. We conducted research around 3 years ago now, on how the research on AI for mental health was conducted. What we noticed is that it was not happening in a clinical scenario at all. Everything was done with pilots, and the data was quite unreliable. So we were very disappointed about what we found. But definitely was something that we would like to repeat to see that is improving, right? That is the risk of AI, right? There is a lot of, that is a buzzword right now. Everybody's trying to work on that. But we are not putting enough attention in how the research is done, and that is what is really concerning us. Then the next piece that we conducted was a bibliometric analysis on telemedicine and dementia. And the final piece is the one that was launched 2 weeks ago, I would say, that perhaps if relevant we could share with the colleagues that are joining the event, so you can also have access. I'm happy to continue doing that. And we will continue advancing in this area, right? I think that there is a lot of things to do. From the digital point of view, the part related to inequalities, that is something that is clearly lagging behind, and is in every single speech and conference that we are putting forward, including by Hans, but our regional director, he's the first one committed to this, and then by us. And that is something that we will continue pushing, because we can see how it's left behind all the time. It's impossible to see. And actually now remembering one of the findings of this AI report that we launched last week, when we were asking the countries about stakeholder engagement, we noticed that the broader population is the least involved in developing AI solutions. So again, we don't need to blame the member states, and actually we had ministers last week reflecting on this, that it was a failure not to involve them. So I think that there is a lot to learn about how it was done, because when you are in the process of developing something like this, you can miss things. And you are so worried about The health workforce, of course, you need to be worried about the health workforce, and the private sector that then you leave things behind. Unfortunately, the things behind is usually us. But I mean, as people, right, as population, but that is something that we take stock. And then from the data part, what I mentioned, right, I think that is a good step that we're establishing this working group that Stefania also will be leading along with Yongjie and our team. And what else we can do when it's about this Health for All database that will help us to bring also the topic and to give more visibility.
It's great. Thank you so much, David.
Thank you so much to all of you for the time. Thank you.
I think if I could quickly summarize, I think we have developed a lot of tools that are available for countries, but also for cities and communities. I think the Knowledge Hub, knowledge community is one way in which we can engage with you, but we just need to think about the type of knowledge communities that you're interested in, that we could perhaps create one that we can work together. And of course, regional cooperations with the Nordics and Baltics, or even arranging sort of lessons sharing from different parts of the region. So thank you so much. Thank you. Could I introduce you to Dr. Stefania Ilinka? I often introduce her as my partner in crime, that we are working together very closely. Stefania, would you like to introduce yourself as we get Lydia up on our screen?
Yes, so I'm very sorry I was a bit late for the beginning of the session. My name is Stefania Ilinka. I work as technical officer for long-term care specifically, and work quite closely with Yongjie on the development of the strategy. But I'd like to pick on that last question, which I think is, David had to go, but I think what we're really trying to do as part of the WHO team is live really to the slogan that Natasha often says, that it is a whole house push. So when we try to address the issues of aging or even mental health, I think is a perfect example. These complex, multi-sectoral, multifactorial issues, it really takes input from different teams. And I think now we're doing better, also in the past year, working closely with the digital health team to see how we can use those tools for aging, how we can use those tools to advance the agenda of mental health. And it's, I guess, a perfect segue, Lydia, then into your presentation. Can you hear us? Yeah?
Great. Thank you, Lydia. Can you hear us? I know you had...
Yes, I can.
Great.
I can.
Thank you so much for joining. We can hear you very well. We have a almost full room. Well, maybe a third of the room, because we're in a parallel session. So I'm delighted to introduce you to Dr. Lydia Lazari, our regional advisor for the Mental Health Flagship Program. So, Lydia.
Thank you, dear Yongjie and dear Stefania, and a very warm good afternoon to everybody in the room. It's a delight to meet with representatives of the Nordic countries. We are in continuous collaboration with, as recent as last week, we were convened at the Danish Parliament by Headspace Denmark, when the participants from other Nordic countries and the Nordic Council of Ministers were there. So this is just a continuation of that collaboration that is going on. I was introduced as the regional advisor for mental health, and I lead the mental health work here in WHO Regional Office for Europe. I have a very short set of slides that I can share with you to kind of put some wood in the fire of some discussion, and I'll be very happy to take questions from you or any discussion that you would like. So do you see my presentation?
Yes, we can see it. If you can
Very
put it
good.
on the
Yes, I'm trying to put it on presentation mode. Is it on presentation mode? No.
Not yet.
Yes. Okay. So very briefly, I'm talking. We are in mental health. We are in a bit of a transition. because we are now transiting, as you might have heard, from the EPW1, which expires, so the European Program of Work 1, which expires this year, into the European Program of Work 2. And there is a very interesting shift of how mental health is conceptualized in those two frameworks for action in WHO. Because in the previous European Program of Work, and I'll talk about that in a minute, we were prioritized as one of the flagship programs for WHO Europe. So that was aiming at elevating mental health into a priority for the entire region, so for the mental health communities, for policymakers, politicians, and so on and so forth, and to talk about how old challenges are now meeting up new challenges, and how, while coping with new challenges, we should not forget about what we haven't been able to accomplish in the past. And I'll talk about that, and will be happy to take your questions about. This picture is from the launch of the Pan-European Mental Health Coalition 4 and something years ago. In September 2021, we came to Brussels, and the Queen of Belgium, together with our regional director, Dr. Hans Kluge, launched the coalition that is serving as an implementation vehicle for this framework for action on mental health. What's important here is I want you to see how wide is the area of operation for this framework for action. And even though it expires now, in a month from now, still it has put some very solid foundations of identifying who in our region are the champions for taking forward each and every of these pillars. And you'll see the first pillar is mental health service transformation, the second is integrating mental health into emergencies, and the third is mental health promotion and protection over the life course. And you will see there in that third pillar, older adults being very well featured there, but also long-term care and support in the first pillar when it comes to provision of active care to people in need. So this is an implementation mechanism for the framework for action, and it has helped to be a meeting point for all those who have a voice, who have an interest, who have expertise, who have a power, who have resources and means to support lifting mental health out of the shadows. Excuse me. You'll hear many of us in WHO talking about lifting mental health out of the shadows. And the truth is that we have inherited a very stigmatized environment where mental health policies and practices have been operating. Mental health is not only heavily, there is a stigma around mental health issues, mental ill health, and there is almost discrimination. There are discriminatory practices against people who live with a mental health condition, regardless of their age, regardless of their social status or their economic status. Stigma and discrimination against people who live with mental health conditions is always there, and it greatly prevents policy actions, it greatly prevents investment, and it perpetuates those practices where mental health is really left in the shadows. So as part of the prioritization exercises with the coalition, 4 years ago, we identified what are our priority sub-areas, and you will see here that under ensuring healthy lives and well-being for all at all ages, one area is mental health of older adults, where we have tried to understand what is the scene, what is happening in the region, but also what are the challenges that we are facing. And certainly part of the challenges, so everybody would think that one of the challenges is, for instance, lack of financing. And it is true, we have inherited very very underfinanced mental health systems, no, and that has made also ideas be left on the side. So many countries operate under very obsolete designs for their mental health systems and services. So financing is one. I mentioned stigma and discrimination, and there are a lot more challenges that you might wish to bring on board when discussing the need to accelerate mental health service transformation. If you are wondering who are the members of this coalition, we have representatives of member states. So each member state, each country has appointed at least one representative. Some countries have more, but we also have NGOs. These can be NGOs from people with lived experience or advocacy NGOs, individuals who live with a mental health condition, and certainly we do not expect individuals who live with a mental health condition to set aside time and work for free, because we want to stop this practice where of a tokenistic approach where persons who live with mental health conditions are brought around the table just to tick a box. And you'll see there are professional associations, WHO collaborating centers, researchers, clinicians, international organizations, and private sector to a lesser degree. Now, I'm sorry, I was not meant to show that. I had another presentation, I'm sorry, but as this is over now, okay. I had obviously I put the wrong set of slides. So because what I wanted to share for you is I shared with you what we did 4 years ago, and it was in a way being mindful of the new challenges that emerged from COVID. What COVID did was that mental health, especially of young people, was deteriorated. Depression and anxiety raised among young people, but we also found loneliness being deepened among older people. So these were the new challenges, but we also had old challenges, and those old challenges were that in many of the countries, of the 53 countries of our region, mental health is still being delivered in asylum-type institutions that do not serve the purpose of getting people better, rather than accommodating them, sheltering them, and out of sight, out of heart, and becoming places where abuse can happen, where human rights violations can happen. And this is certainly a concern in WHO that we have been talking always, and we're trying to support countries in overcoming. So this is the situation of 4 years ago. Those challenges remain, and in addition to the challenges presented by COVID, what we are now finding are new challenges of, as I mentioned, a deterioration of the mental health of the population. We have seen how in 10 years the mental health of the population at all ages has deteriorated, and 10 years, it's a very short period for the deterioration to be very significant. So we are somehow alarmed of the fact that mental health of our population is getting worse. We have new determinants. You talked with my colleague David Novillo about digital health, and we have those digital determinants, such as, for instance, exposure to social media and unsafe online spaces, to which young people are probably more vulnerable. But we also do not want to forget that older people, because of the digital divide, are as vulnerable, especially to harmful practices such as financial fraud and scams, etc., etc. So these are the new challenges that are making our concerns shaping and focused on what we need to do. What, in addition to what I just said, what we have been doing is working with our member states into understanding how their systems work. And what we started by a survey where we asked our member states what, among others, what are the enablers for mental health policy implementation. And it was very interesting to see how almost univocally countries said that where you have intersectoral coordination, this is a sure enabler for policy implementation. And and where you have strong government leadership, this is another enabler for policy implementation. What this means is that health sectors alone cannot face, address, and successfully fight those challenges. Health sectors need to be in tandem with other government sectors so that the challenges are addressed as they should. Luckily, in the Nordic countries, we have great champions. All of the Nordic countries, I cannot single one without mentioning the other. If you want, I can mention how those countries have successfully addressed mental health from a multi-sectoral perspective. For instance, Sweden has been famously developing its current mental health policy through a massive and time and lengthy consultation of 26 government agencies, including the non-governmental sector, where every sector, police, justice, interior, youth, culture, education, have had the possibility to contribute to shaping the future of mental health of the population. Finland is famous for its implementation of the well-being economy. Iceland is famous for having addressed mental health of young people through a multi-sectoral lens. Denmark just a couple of years ago approved its national mental health strategy, again through a process of consultation, wide consultation with several government sectors. And this is true especially in digital mental health, where that Denmark has done a very, very good work in achieving that. So we have good practices from the Nordic countries that we are trying to emulate for other countries and show that don't get distracted by the fact that we do not have sufficient resources. It is true. Countries do not spend enough on mental health, but we also need to be smarter into finding out how to use the resources we have better. And an example for that is, for instance, those of you who have children in school, you would know that schools do have mental health professionals there. But what you probably do not see is, are those mental health professionals talking, or health professionals, a psychologist and a school nurse, are they talking to the specialized mental health services when there is a child or a young person that is having a difficulty, so that the resources that the taxpayer money is put into either education sector or health sector or social sector, but through virtue of coordination, are used well. And another lesson learned we have from the discussions, and I think this is relevant for this audience, another lesson learned is that in our bilateral discussions and dialogues with the member states, one thing that is very clear is that local action is essential for bringing change. So we may have enlightened leaders at the national level, but unless their actions, unless their policies are well accommodated, well received, well embraced, and also operationalized at the local level, we wouldn't be able to do what we need to do to achieve a better mental health for everyone. I don't want to spend more time because I think you probably have questions, and I want to see if there are questions. Over to you, Yongjie.
Thank you so much, Lydia. Thank you so much, Lydia, for your presentations and overview of the mental health flagship programs. And you rightly say so that, of course, we really do need to bring mental health out of the shadows, and local actions is so important. So this question is to you, Lydia, and also to all of our colleagues here on the floor. What do you think are the greatest potential from the municipalities to contribute to better mental health outcome of all the persons, and to bring this mental health issues out of the shadows to address the stigma? Maybe someone from the floor, to Lydia, for comments. I'm going to come to the floor with the microphone. Any examples that you would like to share about your mental health programs and how you involved older persons or other sectors? As Lydia mentions, one of the key enablers is working across different sectors. Any examples? Hannah.
So hi, my name is Hanna Dunning and I work for the Danish National Network of Healthy Cities. And just an example from what we're doing is we're really trying to focus on the mental health promotion we use a program that we adopted from Australia called ABC for Mental Health, and it stands for Act, Belong, Commit. And it's really this idea of community building and engaging people through whatever hobby or activity they see. And I think we've seen that is very successful from the presentations we had earlier today, that really listening to what people want to do and getting them involved really can be a mental health promoter. But I guess then I had a question to Lydia, if I may. I was really happy to see that one of the pillars was this mental health promotion throughout the life course. And I was wondering if you guys have a collection of some good best practices or tools out there that we could be drawing from when focusing on this promotion side. Thank you.
Thank you, Hannah. Lovely to see you on the screen. Just commenting on ABC, this is one of the good practices that has been selected for the EU Joint Action PRISM. No? And we had representatives from the Joint Action PRISM because the leader of that working package are indeed in Denmark. So we had the pleasure of hosting them 2 weeks ago in the UN city, in that very room where you are, and engaging everybody in discussion. So the ABC that is being implemented in Denmark is really serving as a learning point for other countries participating in this EU joint action. In terms of promotion and prevention, one thing that it's very clear when we discuss with countries is that there is virtually no country investing enough in promotion and prevention. And for instance, one figure that comes from the latest publication from WHO is that the WHO published Mental Health Today. It's a document that you can find online from September this year. And one of the things there, it's the topic of research. So it's very interesting to see that while the burden of mental ill health is enormous in every society, the proportion of mental health research globally is 4.6%. And only in the high-income countries, which is the countries represented in that room, it goes up to 8%. And what's very interesting is not only the absolute figure of how much we pay for mental health research, but it's also within that 8% figure, half of it is on etiology, trying to find what are the causes of the diseases, which is, if I can afford myself to say, somehow obsolete, because a lot of diseases have been well researched, and we do not invest enough. Out of that 8% that is spent on mental health, out of the global body of research, in that 8% of high income countries, only 7% is on prevention. So that tells you a lot. While, for instance, at the same time, we have seen a drop on suicide. Especially the European Union is a champion of having curbed suicide globally. What that means is that the instruments we have at hand for preventing suicide do work. Of course, we should not be happy because there are still too many deaths due to suicide. So the success of suicide prevention, I'm not saying let's go to sleep now because we achieved. No, not at all. But what it means is that the prevention instruments do work, and the countries are not using them sufficiently and are not using them enough. And probably because it's in many countries, mental health staying at the hands of the health sector alone, prevention policies are not used sufficiently enough. A lot of prevention can be done at the schools. A lot of prevention can be done around the perinatal period for both the baby and the mother. So, and I had a slide, I'm sorry that I put the wrong slides on the screen, but I had a slide showing how the countries, what kind of programs have been more successfully taken up from countries. And the three following programs have more than doubled across the WHO member states. The first is suicide prevention. The second is early childhood development and perinatal mental health care. And the third is workplace mental health. So we are having a kind of an awakening among the member states on the importance of prevention. Things are getting better, but we still, for instance, by not investing sufficiently on researching prevention methods, prevention, the success of prevention, evaluate the cost efficiency of prevention methods, we are probably doing a disservice to the potential that those prevention strategies have of making people better. I don't know, Hannah, if I responded to your question.
Thank you, Lydia. We have a comment from our co-moderator.
I think that was an excellent response. I don't know if a comment or a question, because I'm looking at the room and I'm going to jump in if I have the chance. Lydia, where does brain health sit in relation to mental health, especially in the older population? Because you said the Nordic countries are global leaders on mental health, but I can also confidently say they are global leaders on dementia prevention, diagnosis, and care. So I'm wondering how the two come together, because, and I'm going to take a quick poll in the room. In your municipality, in your region, do you have dedicated dementia care and prevention support programs for older people? Yeah, I see a few rooms, a few hands, maybe. So at least it seems to me more than mental health for older people, and that's an interesting, maybe, reflection of, I don't know, maybe aging stereotypes as well. Please.
Okay. Is this to me or is it some? Okay.
No, it's to you. It's to you.
Thank you, because I'm not sure to who you were looking at. It is a very, very good point, and it was in my missing slides. I apologize again for that. What we see in terms of mental health of older adults, we see two trends. One trend is that because of the mental health of young people has deteriorated with high speed, there is a focus, all the countries now are running after making sure that their young people get the support they need. And we are trying to be cautious in WHO by this, while of course we applaud that, but we don't want this to be done at the expense of older citizens, because there is a risk there that there is less talk about older citizens. When you couple this with a certain tendency from certain countries to accept, and there is it's also a health behavior in a way, to accept a cognitive decline as a part of normal aging, then the risk is even higher of neglecting early recognition and prevention efforts for addressing brain health issues among the older population. So again, the Nordics are with their actions to support multi-sectoral and across all societies, so at the national but also at the local level action, are paving the way and are giving the examples. But again, I'm confirming that our concern now is to make sure that mental health of older adults is treated with due emphasis, and not falling into the stereotype of cognitive decline being a normal part of old age.
Are there comments, maybe other questions from the room? I think we still have a minute or so. No? Oh, sorry, I didn't see.
Thank you. My name is Gisli. I come from Iceland. I don't have a comment or question. I just want to tell you a little story about our homes in Iceland. We have 3 nursing homes. well, we have many nursing homes, but I run 3 nursing homes in Iceland, and one of them has people with mental problems in Copenhagen, a small town of 3,000 people living there, and we've been running this business since 1962. And I think we have to mention and approach that people have to have meaning in life. They have to have some role. So we are getting these people in our home, which are some of them are rather seriously mentally ill, and try to give them something to do. Just some small assignment, just to raise the flag when there's a flag day, to put the chairs in the dining room up on the tables, and as soon as you give them something to do, some responsibility, it doesn't have to be much, just some tiny thing. They think they are important, and they feel important, and they don't feel useless, as was mentioned earlier today. Loneliness, same as uselessness. If you give them something, some role, something to do, it's important in nursing homes, and it's also very important with dealing with mental health problems. So let's try to get them into society, some responsibility, some role, and we'll all be better off, especially they. Thank you.
Thank you.
Thank you. And this is indeed very much the paradigm shift that we want. It's the transition from institutional asylum type care to community care, including residential care, should indeed go through that philosophy that people need to feel they have value. And when you go and ask people, even people who live with a severe mental disorder, about what are their dreams, what are their aspirations, we, the lay population, always get very surprised when we discover that they have the same dreams and aspirations as everybody else. So I cannot agree more with your point of giving value to people's existence and to people's lives, even by engaging everybody in an activity that has a purpose. So thank you for making that point.
Lydia, I don't see any questions, but then maybe one final reflection from you, because you talk about how important it is to involve different sectors, working with local communities. What opportunities is there that we can work together with local communities? Are there any examples through your work?
Yes, there are a lot of examples. We had a meeting in Paris in June this year, where we had an entire session dedicated to how local communities, how local governments can contribute to making mental health of their citizens better. And we are very soon going to publish a report on that, so there you will find a bit more information. But what municipalities, what local governments can do is, first of all, make spaces friendly to people with disabilities, people in cognitive decline, people who have difficulty in socializing, that are experiencing loneliness. So what we see, and I don't know if this resonates with our colleagues from the Nordic countries, but what we see in many pockets of our region, we see a wild urbanization of our cities. And this is indeed threatening the possibility for people to get connected. So what we are trying to see, and that's why, for instance, in Paris, we also had urban planning, Ministry of Urban Planning from France, to highlight the need for planning urban spaces with in mind the need for making the spaces friendly to people who are experiencing loneliness, who are experiencing cognitive decline, who are experiencing mental distress. So I don't think we have time to go through examples, but local governments can not only contribute with concrete funding for instance, non-governmental organizations or community initiatives, but also when they plan their spaces, they should do that with in mind their most vulnerable citizens.
Great.
Oh, this is excellent. Thank you so much, Lydia. We're out of time, but I want to give you 30 seconds to just very quickly pitch the MEND survey as well, because this is a recent WHO publication that has made an enormous impact on me. And I think everyone should read about it also because, we have here, I think, some of the stakeholders who can drive some change in how health and social services are organized. And then we'll let you go, I promise.
Oh, it's a pleasure too. I always love talking about my work. I love my work, as you can see. The MEND survey is a survey conducted with doctors and nurses of the 29 member states that are under the contribution agreement we have with the European Commission. Those 29 are the 27 EU plus Iceland and Norway. We had about 121,000 responses from doctors and nurses over all these 29 countries. Only about 90-something thousand were valid responses, and what we found out was very concerning. It was a clear indication how much our health workforce is suffering. We found out that 1 in 3 doctors and nurses are living with symptoms that indicate depression. 1 in 4 are living with symptoms that indicate anxiety, and 1 in 10 have had passive suicidal ideation, meaning the passive thoughts of ending their lives. These are alarming. We also have data, I'm only focusing on those 3, but we have a lot of figures about violence in healthcare, violence against our healthcare workers, healthcare workers that are planning to leave, are thinking of leaving the profession, etc., because of the unsuitable working conditions. This is very alarming. Being a healthcare worker a few decades ago used to be a very prestigious status. But now we see from COVID how our healthcare workers have suddenly become a vulnerable segment of our population, and we cannot afford not to take care of that if we want our aging populations to receive the care that they are entitled to and that they need. So this is a call for action. If you have any power to influence making things better for healthcare workers in your communities, I would strongly, strongly advocate for you to do so, and would be very happy in WHO to stand by you and work in designing concrete measures in addressing that.
Excellent. Thank you so much, Lydia. Thank you very much. Thank you for being patient.
So we have about 10 minutes break for our last sessions of the day. We'll be back here at 4:35. So coffee break is behind you. Thank you so much, everybody.